Thanks, Alan. I'm very happy to be here. I'm particularly happy to have the opportunity to give this talk because I know Dave Crawford, almost every single time I hear him speak, says we got to get rid of active surveillance. It's over, it's dead. And I don't think that's entirely true. It's gonna stay with us, although I agree with the basic concept that taking steps to improve screening and reducing overdiagnosis and less low-grade cancer is laudable. So this is not a new idea. Our first publication was 2002, and the basic concept began about 20 years ago. It was obvious that to us that there were a lot of patients being treated with indolent disease, but there was no kind of described way to get around this at the time, and there was a strong sentiment that all newly diagnosed patients should be treated. So it's now a new era. There's no disagreement about the issue of overtreatment, I would say. I saw the vote earlier. Most people think even today, with better understanding, there's still some overtreatment going on. We know much more about the nature of occult high-grade disease, which is the Achilles heel of the surveillance approach, but we're getting a better handle on that. The predictive value of baseline parameters, PSA density, race, age, of course, biomarkers, the flaws of PSA kinetics as a trigger, which was relied upon by most groups for the first roughly 15 years of this era, but not anymore, sensitive but not specific, the game changer of multiparametric MRI, new modeling studies and longer follow-up, and the last time I did a PubMed search on active surveillance and prostate cancer, 2750 publications on this topic. So there's a consensus of what most people who are in this field agree upon. First, that we know much more about how the molecular genetics of Gleason 3 and 4 compare, and they are like night and day, and I'm going to go into that in a little bit of detail. And the corollary of that is the metastatic potential of Gleason 3 is now acknowledged to be essentially zero. And I have asked many audiences over the years who has a case of a patient treated with prostatectomy, so you don't have the issue of misattribution of grade from the biopsy, where it's pure Gleason 6 and the patient goes on to recur and metastasize. Almost no cases. And the ones that there are is a handful you have to wonder about. So I think this is a fair statement. Whereas as soon as you have Gleason 4, you have a real cancer, and we have mounting evidence for that, which I'll review as well. And so I think it's well known now the Achilles heel of the conservative management of the Gleason 3 grade group 1 is that about 25% of those cases harbor higher grade cancer. Now, most of them are Gleason 3 plus 4, and they also may not represent that much of a threat during the patient's lifetime. But tremendous efforts now to identify those cases earlier, and it's become quite clear that the failures of surveillance were the patients who harbored the high-grade cancer at diagnosis in almost all cases. In contrast, going from pure Gleason 6 to Gleason 7 or 8 over time, biologic progression is actually quite rare. We know there are cases, probably around 10%, that are Gleason 6 who harbor molecular genetic features that are adverse, and this is the basis for the Prolaris and Oncotype DX, and clearly those have a role. There's a lot of really important data. Recently, we started to hear about this earlier on germline mutations, particularly DNA repair mutations, and that has very significant ramifications for those patients who harbor the mutations who are contemplating surveillance. And then, of course, the complementary roles of MRI and biomarkers. This pointer is driving me nuts. I mentioned the two species of wolves in sheep's clothing, the misattribution of higher grade cancer. You see the Gleason 6, but the patient's got something worse, and this is the real problem, around a quarter of cases. There's very little known about this rate of biologic grade progression, which is surprising considering how fundamental an issue it is. How likely is the guy with, say, extensive Gleason 6 to progress to higher grade cancer? There's 3 papers on this. One is from our group, one is from Hopkins, and the best one is this modeling study from Ruth Etzione's group. They all calculate roughly 1% to 2% per year of grade progression, usually in a field of large volume Gleason 6. So this means in the short term, it's not really an issue. In the long term, you're following patients 10 or 15 years, they have a, say, 15% chance of grade progression. Again, not necessarily to lethal cancer, but they need long-term follow-up. This issue of non-metastasizing Gleason 6, very fundamental. 2 studies, well known, just briefly, the Eggener study of 12,000 Gleason 6 treated with surgery. They basically did not find one patient with true Gleason 6 who confirmed on re-review who metastasized. They report 2 in 1,000, but they were all upgraded eventually. And the same thing with the Ross paper, 14,000 cases, essentially no pure Gleason 6 that metastasized to the lymph nodes in all those cases. So this is pretty compelling evidence, I would say. And even if it is 0.01%, it doesn't mean that you should alter your management based on this. And I mentioned the very comprehensive understanding now of how 3 compares to 4 in terms of the pathways of oncogenesis. And if you look at proliferation, apoptosis, angiogenesis, response to growth signal inhibition, and so on, it is remarkable how Gleason's low-power view of the acinus aggregates cells into those with very normal-looking molecular genetics and those with abnormal. Now, as you'd expect, there's some exceptions. One exception is P10 loss, which is a key molecular event in the pathogenesis of invasion and metastasis. 10% of Gleason 6 reported to have P10 loss, but versus around 90% in higher grade cancer. This is a study from Mark Rubin's group that's grade group 1 on the left, grade group 5 on the right, and it shows the mutational burden that increases dramatically as you go from low grade to high grade. So you see high grade prostate cancer, it has a absolute plethora of mutational events. And on the right, you can see here, this one is P10 loss. So it does occur, but as an isolated event, it doesn't seem to have much in the way of clinical significance. Again, these patients don't metastasize. One reason for this is a study published last year, a preclinical study, but it showed basically for P10 loss to result in metastasis, you needed coexistent MYC activation. And you can see the top line is MYC activation or P10 loss, and this line, all the animals died, is the combination. So it makes sense. You have the odd sporadic mutational event that does not translate into metastasis because you need a combination of events, a kind of 2-hit hypothesis, to really get lethal disease, and you basically do not see that in low-grade cancer. It turns out that those patients who have Gleason 6 who do have P10 loss tend to be the cases where there's coexistent higher-grade cancer. So this just shows, this is a large group of patients from Hopkins where they had Gleason 6 or 7, and they teased out the Gleason 6, and this is the incidence of P10 loss in the 6, the 3 plus 4, the 4 plus 3, and it goes across here. The P10 loss tends to occur in Gleason pattern 3 when there's pattern 4 present. So there's 2 possible explanations for that finding. One is that you're seeing the 3 on its way to a 4. And so you have 4 present, and it just shows the maturation. The other sort of intriguing idea, which is getting a lot of airtime recently, is this intracellular communication through the means of extracellular vesicles, extracellular vesicle transfer. And it turns out that particularly these high-grade prostate cancer cells are shedding, each cell can shed thousands of these extracellular vesicles per day, which harbor biologic material, including microRNA and messenger RNA and protein, and they may result in silencing of genes in the cells that take up these extracellular vesicles. It's been shown in an animal model the high-grade cancer will induce a more aggressive phenotype in a low-grade cancer. So it's high-grade, low-grade, and it's like the good cancer has gone into a bad neighborhood and been adversely influenced. So this has a lot of implications for a number of clinical scenarios, and certainly one explanation that's kind of counterintuitive. And another thing we don't think about too much is actually spontaneous regression. And in a third of low-grade prostate cancers rebiopsied are negative, and we always assume that's just sampling. It's small volume, you miss it on the next biopsy. In breast cancer, it's widely acknowledged that spontaneous regression due to lack of telomerase, inborn senescence, lack of VEGF, score of reasons, and the cancers disappear. And it's quite plausible that this is it's certainly widely acknowledged in breast cancer and probably in our area. So if Gleason 6 is not metastasizing, why do we worry about larger volume? The reason, and every guideline differentiates between very low risk, which is Epstein criteria in most cases, and just low risk, which is higher volume Gleason 6. And it does make sense because the volume is a marker for the presence of coexistent higher grade cancer. And this is one recent study that incorporates PSA density and laterality. If it's bilateral, it's higher volume, and the number of positive biopsies, and very low versus low risk. So there's clinical parameters that allow you to very well predict, based on mainly on tumor volume or surrogates for tumor volume like PSA density, who harbors the higher grade cancer. This is a summary of 9 prospective series of surveillance in the literature. There's now more than 10,000 patients, including the huge Prius multinational collaboration. But I just want to compare these two. So ours and Hopkins, and the reason, these are two of the largest and most mature. They started around the same time. They both have well over 1,000 patients, but we took completely different perspectives. And our perspective was an inclusive one. We offered surveillance to everyone we thought was a reasonable candidate, including Gleason 7, particularly small volume 4, and we weren't too worried about the PSA being less than 10. And Bal Carter at Hopkins, for a variety of reasons, philosophy, maybe fear of litigation, who knows, took a very conservative, restrictive approach. I won't say very conservative, let's say conservative, restrictive approach, just Epstein criteria, and they treated for volume progression of Gleason 6. And this is our kind of last data. We had 22% intermediate risk. Now 1,400 patients, 30 metastasizing patients, 15 died of prostate cancer. This came out about 2 years ago. 5% actuary mortality, although the raw rate is 1.5%. And for about 6 months, I was very proud of this paper. I thought, 5% mortality with 15 years follow-up in a prostate cancer cohort is pretty good. And then my ebullience was destroyed by this paper from Hopkins, where also 15-year outcome, 0.5% mortality. So there's clearly was a benefit to this more restrictive approach that they took. So we looked at our data to try and figure out, why did we have a higher mortality, even though 5% is, I would say, not bad, but obviously room for improvement. And it basically was all the intermediate risk patients at baseline who accounted for the deaths, the hazard ratio 4 times greater for the intermediate risk. And it wasn't the PSA, it was all the presence of Gleason 4 at baseline. This is the recursive partitioning analysis. Gleason 6 over here, they all have like 90 to 95% actuarial 15-year metastasis-free rates. But in the Gleason 7 here, even in the best group, small volume, PSA less than 10, 3 plus 4, 30% calculated metastasis rate. So that was a wake-up call. There's a lot more data that's come out recently on this issue of the safety of surveillance for Gleason 7. Just a paper from Hopkins that looked at Gleason 3 plus 4 who had radical prostatectomy. And these were favorable 3 plus 4s, just published in JAMA Oncology a month or so ago. 25% of the favorable 3 plus 4s had adverse pathology, meaning predominant 4 plus 3. And most strikingly, there was no predictive factors to identify who the high-risk groups were. So this was a very sobering study demonstrating that any 3+4 at diagnosis was associated with a relatively high risk of harboring high-grade cancer. Now, in contrast, you have this group from Cleveland Clinic, Andrew Stevenson, 117 intermediate risk on surveillance, 5 and 10-year metastasis-free survival, 99%. No difference in metastasis, surveillance failure, or curative intervention compared to low risk. So this is a controversy at the moment. There's clearly intermediate risk patients who are candidates for surveillance, and lots of these patients do very well, but it's riskier. It's a lot riskier than the Gleason 6, particularly the ones who are well characterized, and caution is warranted. To make a long story short, comparing the Sunnybrook and Hopkins kind of initial approaches, inclusive, restrictive, 50% eligible versus about 15 to 20% of newly diagnosed eligible. So that's the downside of a restrictive approach. The benefit, a few fewer deaths. There's clearly been a convergence. I think the Hopkins group acknowledges that most Gleason 6 are candidates, and we're much more cautious about the intermediate risk than we were. This is another publication from our group that compared 9 different surveillance cohorts as to the intervention rate. And Hopkins is down here, we're up here, we're a little higher, but what is striking is this is all varies between about 20% and 30% intervention rate at 5 years. So the interesting thing is it seems no matter what your basic eligibility are, whether you're stringent or inclusive, the intervention rate remains about the same. Let me just go on a bit. MRI we're going to hear some more about, but it's obvious that this is having an impact. This is a typical case of a guy with mild elevation of PSA, systematic biopsies. We don't do template, but showed a single core, 10% Gleason 3. In the old days, we would have just, rebiopsied him a year later. Today, he has an MRI. There's the lesion there. You would never hit that with a systematic biopsy. There, that was a Gleason 4+3. There's the radical prostatectomy specimen. As is often the case, the actual lesion was underestimated on the MRI, although it was identified. Here's the microfocus of Gleason 6. So this is an anecdote, but I mean, clearly this is going to make how we do things better. This is a summary of the 15 or so studies that are out there that look at the accuracy with which MRI can find higher grade cancer. And you see the NPV over here of all these studies. If the MRI is negative, how likely are they to have disease? And there's a big range. I mean, we want this to be 90 to 95%, but the range is from about 80 or less to 100. The Pano-Bianco study, not one MRI negative with clinically significant cancer in about 1,000 patients. Frankly, I think it is literally incredible. It is not plausible, and we've seen many more than that. One of the important considerations about this is the NPV is a function of underlying risk. This is a recent publication from the EAU guidelines panel that just emphasized if you have a high-risk population, the NPV of MRI is relatively low, around 65 to 70%. In a low-risk population, it's more like 90%. So the NPV is a function of risk, and you have to keep that in mind when you're looking at your patient's negative MRI and deciding whether to go further. We did one study that's relevant, that's just under consideration for publication by European Urology. 275 men on surveillance, randomized between MRI with targeted biopsy and systematic biopsy alone for their confirmatory biopsy. Come on, baby, move. Oop. We used the Artemis device, which was one of the issues. We bought 3 of these devices with the funding for the trial. And next slide. I just want to basically show some brief results. We were hoping to show that if you did targeted biopsies, you'd find as much intermediate risk cancer as if you did systematic biopsies. And we didn't. And the thing that, if you look at here, we had 3 different sites. So the middle site was the largest one, and if the patients had a PIRADS 3, 4, or 5, 1 in 3 had significant cancer at the largest site. At the other two sites, which didn't accrue as many patients and clearly didn't have as much experience with the Artemis device, the positive predictive value of a positive MRI finding was 10% or less. 90% of those patients having targeted biopsies had no evidence of significant disease. And furthermore, the targeted biopsy did not find as much, next slide. The targeted biopsy did not find as much cancer as the systematic. So this partly reflects learning curve. It partly reflects, I think, limitations of the targeted biopsy approach. Not all significant cancer shows up on MRI. And at this point, I mean, in a low-risk group, I think it's quite effective. In the higher-risk group, they still need systematic biopsies. One of the important considerations in identifying intermediate risk patients who are candidates for surveillance is the key group who have 5% or less Gleason pattern 4. And I don't know if this is well recognized. Patients who have very small amounts of pattern 4 are very prone to have artifactual upgrading because of tangential cutting of a Gleason 3 acinus. The needle misses the lumen, and all you see is a clump of cells, and a pathologist who's trying to quickly get through a large number of cases will call it a Gleason 3 plus 4. And they tend to be just a small amount of 4. And one of the proofs that this is a real phenomenon, next slide, is this is one paper from NYU, Samir, Tunisia, that showed the cases who had less than 5% pattern 4, Gleason 3 plus 4, less than 5% on biopsy, had exactly the same distribution of radical prostatectomy pathology as 3 plus 3. In other words, more than 60%, 65% were only 3 plus 3. The Gleason 4 disappeared. And so these are a special group. More than 5%, or certainly more than 10%, I think, active surveillance at the moment, probably not the best strategy. The biomarkers suffer from one limitation, which we're intimately familiar with in prostate cancer, which is heterogeneity. So this was a gorgeous study where these authors took a small group of patients, it's 4 different patients. These patients all had multifocal cancers. So each bar here represents one small cancer in the same prostate. This patient, for example, had 6 different cancers. They did whole exome sequencing on these microdissected cancers and then ran the panel of Oncotype, Prolaris, and Decipher for each of these cancers. And what do you see? You see a lot of heterogeneity. You see high scores, low scores, positive, negative. They tend to trend in the same direction, but remember, these are quantitative assays, and there's heterogeneity. So what does it mean on this patient if this is the readout of Oncotype and this is the rest of his cancer? So I think that's a challenge for the biomarker area. They obviously have a lot of predictive value, but it's something to consider. One more aspect of this is what you could call the Bayesian problem. You have a patient with grade group 1, favorable features. We know he's got a 3% chance of metastasis at 15 years, even less if he's at Hopkins. You apply the molecular diagnostic test. Let's say it's 90% accurate. You have a 10% chance of a false positive, which is between 3 and 10 times higher than the patient's actual risk of having significant cancer or metastasis. So there's a real risk of a false positive in the very low-risk patient, and by the same token, in the very high-risk patient, you have a 4 plus 3. Dave mentioned doing the tissue-based molecular assay in these patients, but I would have a lot of difficulty counseling conservative management in a 4 plus 3, no matter what the tissue-based molecular assay was. So you need the right test in the right patient with the right risk level. The final point I want to make is about this incredible data on DNA repair germline defects. What we have learned is that the mutational burden in patients who have BRCA2, BRCA1, ATM type DNA repair defects accumulates with incredible rapidity. What happens is, as soon as these patients have the initial event, it's like there's an explosion of mutational events. And this study took a small group of patients who were BRCA2 carriers, and they found in the patients with localized prostate cancer, their genetic burden was the same as metastatic CRPC. And you can sort of see this schematically, and along the bottom, the sporadic cases where they start to get all these different hypomethylation, amplification, et cetera, late in BRCA2, they get them very early. I don't even know if there is such a thing as Gleason 6 with a BRCA2 mutation, because the evidence suggests these patients progress so rapidly. But I think when you do find a surveillance candidate who's got a germline mutation, and you need to suspect it from family history and so on, today I think that patient should be treated. I'm going to stop there because I'm out of time. Thank you very much.